أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين. My dear friends, we are talking actually about the complications associated with cirrhosis of the liver. Although many lectures has been uploaded before 1 month, before 1 month or 2 months back, I don't remember exactly, but I have covered the whole gastroenterology, which are important to the physicians and students. Now, these are the complications of the ascites actually which arises in the ward. Ascites is the complication of the cirrhosis of the liver. While ascites itself has got the complications. So the house officers in the wards. Try to understand what is written here. I am Professor S.Ali Heather, and I am honorary professor of medicine. And it's globally on the line, and non-professor without any fame or any economics involving. I do not need money or femininity. My aim is that you should be confident while you are dealing with the ascites. Now this is the abnormal protrusion of the abdomen or enlargement of the abdomen. We will examine this patient from head to foot and then enumerate your findings, and then do the physical examination. If it is all over, there is a note which is tympanic note. It means this is not ascites exactly. This distension occurs because of the gas production in the abdomen. If it is slightly dull only, it means that all over globally, it means that the fat is accumulated. There are 2 layers of the fat in the abdomen, and deep fascia and the superficial fascia. So that's why if you tap it, there is slight impaired notes. If it is dull to stony dull in these areas, which are gravitating part, for example here, a lumbar area and this lumbar area, or in the hypoglycemium, or here, depending upon the amount of the fluid which is accumulated in the abdomen cavity or peritoneal cavity, then you can ascertain how much fluid is collected indirectly. So the ascites is nothing but fluid in the peritoneal cavity. It is the serosa, parietal layer and the visceral layer, and between the two there is the accumulation of the fluid. Already there are mesothelial cells which are secreting the peritoneal fluid, which is important in the maintenance of the lubrication, because there is a lot of activity occurring intra-abdominally. So they avoid friction of the two surfaces. But you cannot detect this. This is hardly 5 ml, under 5 ml, up to 10 ml under. It is normally secreted per day in the person in the peritoneal cavity. Now the mechanism of ascites I will explain, like it is the cause of this cirrhosis of the liver, cause the portal hypertension. It will cause increased nitric oxide. It will cause vasodilatation. It will cause then the renal sodium retention, and retention will cause the overfilling of the intravascular volume, and then ascites formation. Ascites formation will cause the activity. The sympathetic nervous system will be activated, renin and aldosterone mechanism will be activated. So again, sodium retention occurs more, and this is the vicious circle which is going on. Endless vicious circle. So it is refilling and refilling of the fluid. This is the basic concept. Up till research, there are many theories have been given in the books or in the journals. One theory is underfilling theory, which means that actually there is shunting of the blood because of the dilatation, splenic dilatation, the fluid of the body. Most of the blood volume is distributed inside the vascular system of the abdomen. And this is actually because of this, the intravascular volume will be depleted and it will act by a negative feedback mechanism. It will cause the sodium retention and so on. This is underfilling theory. This is the underfilling theory. Another theory is the overflow theory. That here they said that the acute primary abnormality not inside the splenic system, vascular system, but it is outside it, because there are fluid which is accumulating in the peritoneal cavity, sensed by the other system of the body, and because to the body it seems to be a dehydrated patient, and will act just like a person in a dehydration. And it responds by absorbing more water and more sodium from the kidneys. This is overfilling theory. And third theory emerged that the peripheral arterial vasodilatation hypothesis. Of course, because of the lot of it is balanced between the vasoconstrictor and the vasodilators. It is disturbed because of the large accumulation of the fluid inside and the receptors which are present inside the peritoneum, which will act, and the balance between the vasoconstrictor and the vasodilators are disturbed. There is, like, for example, elevated levels of the serum epinephrine and norepinephrine, well documented in comparison with the nitrous oxide. And there is a portal hypertension. If you say there is portal hypertension, it means that you are increasing the pressure of the hydrostatic pressure. And because of the cirrhotic patient have got low albumin, there is the pressure which is called the oncotic pressure is also increased. And they pull the fluid outside, to intravascular to the extravascular spaces. Like, for example, in the abdomen, peritoneal cavity, or the peripheral parts of the body. These are the different mechanism which is going on. And one of the workers said that actually the liver weeps by hepatic lymph. There are very important lymphatic system in the liver. You know that about it. And the reticular endothelial system is there, and there is a lymphatic system operating in the liver. Because of the high pressure created inside the liver weeps from the surface and the fluid accumulates. This is another theory. There are a lot of other mechanisms operating there. Renal factors are also very important. And one is the already said about the angiotensin and aldosterone mechanism, and another one is the etiologic peptide, which is also important hormone. It is insensitive. Actually, it should be sensitized of the changes going on in the intravascular system. It is insensitized or insensitivity to this anti-natriuretic peptide will cause the elevated concentration of the patient with the sodium, and again and the water also. Some of them said that they are also dependent on the angioarginine vasopressor. That is the ABP is overactive and is causing the more of the sodium water retention. These are the theories. A new theory which has come as, in 2015 or 2014, that there is another hormone which is called endothelin, a potent vasoconstrictive peptide it is, and while elevated levels have been reported by workers, the endothelin can cause this type of problems. Anything there are about, it means that if you sum up all this, so there are about 11 and 12 theories have been given. And the overall, summarizing the all theories in one is this, which is presenting in front of you. So you should understand why the fluid is accumulated in this, and why it is not accumulated much in the pleural area. Why in the sun, not in the synovial? Why not in the other areas where the serous membranes are there? This clears this. Because of this, of the many theories which I have just given, and although there is a peripheral edema, yes, that must be definitely cause behind it, but the accumulation of fluid inside the peripheral cavity has been explained like this. The causes of ascites. The causes of ascites are other than cirrhosis, which is the main cause. Right-sided heart failure, which is called cardiac cirrhosis, can without cardiac cirrhosis can cause heart failure. The right-sided, and it can cause ascites. Like kidney disease, nephrotic syndrome, because of the hypoalbuminemia and other causes as well, will cause the fluid accumulation, and low albumin in cases of the malnutrition and in cases of kwashiorkor and in other conditions, and the proteinurias, that is called the proteinuria through the GI tract, can be one of the cause of it. And peritoneal infection like tuberculosis, yes, it is important cause, and that is peritoneal tuberculosis. Remember, you said the abdominal tuberculosis is the word. It is divided into two. One is peritoneal, secondly is the visceral tuberculosis, and third is both peritoneal as well as visceral. There are three types of the abdominal tuberculosis. And lastly, but not the least, are the peritoneal cancers, mesotheliomas arising from the peritoneum. The presentation is that there is history. We take the history definitely from very, very cautiously from what happened and what happened and what happened. They said that they have noticed that there is increase of the weight and increase of the abdominal girth, etc. With some of the other symptoms as well of the chronic diseases type of the symptom, like the epigastric fullness and constipation, weakness and breathlessness. And then the physical examination is the examination to reveal the bulging flanks. You do the properly this examination, palpation, percussion, auscultation, etc. To find that is bulging flanks, the shifting dullness can be well demonstrated, and there will be a fluid wave that is called the fluid cell can be demonstrated. Okay, so this is how we do this. So it means that you become a doctor. If you are a doctor, you should understand the pathogenetic mechanisms which are operating now. this is how we deal with these patients. So I will stop here for a while. This is ascites which I have given. Just see what are the presentation. I'll stop here because further this is the diagnostic criteria of it. It is important. First of all, I see the theories, how it occurs. Secondly, the presentations in the persons. This is only the lecture of about 15 minutes. So we will divide into 3 parts to understand well about this condition, rather going a very, very long lectures and tutorials. We will meet again with the second part of it, inshallah, today, inshallah. I will say today we will complete this Ascites, and no loop will be there. Loophole will be there, inshallah. Assalamu alaikum.